Thank you very much for that kind introduction and also for the invitation to speak today. I'm going to be talking about the changing epidemiology of lung transplant and focus on an international perspective. These are my disclosures. So over the next 20 minutes, I'm going to describe some of the evolving transplant rates over time. I think everybody can agree in the room that we've seen some significant changes over the last few years. And then characterize who exactly is being transplanted nowadays, and summarize some post-transplant outcomes. These are some graphs from some registries around the world, so the European, UK, Canadian, and USCF registry. And they have number of transplants on the y-axis and time on the x-axis. And you can see that over time, there has been a trend in increasing transplants. And I specifically stopped these graphs in 2019. Of course, 2019 happened, then 2020, and some significant changes happened over that time period with the availability of ETI, elexacaftor, tezacaftor, ivacaftor, as well as the pandemic that impacted transplant rates over the world. So what do we know about transplant rates in the era of CFTR modulators? Well, looking back in 2018, there was a publication, a real-world observational study that described the impact of ivacaftor compared to a comparator group using US registry data as well as UK registry data. And although this study focused on many different outcomes, they did comment about the impact on death and organ transplantation, and this is a figure from that study. And we can see that there is definitely a decreased proportion of people who died or who were transplanted who were started on ivacaftor, both in the US and in the UK. And it was statistically significant in the US, not statistically significant in the UK, but that was likely related to a sample size issue. So going back to those graphs, I now have added in the 2020, 2021, and even 2022 to the graphs that I showed you initially. And you don't have to be a statistician to see that those rates have significantly decreased in terms of the number of transplants that have occurred across the board in Europe, UK, Canada, and the US, and I'm sure many other parts of the world. So what is the cause of that? Obviously, the pandemic played a role because we know that during the pandemic, some of the transplant programs were closed. They weren't doing as many transplants. We also know that the pandemic reduced the number of pulmonary exacerbations that our patients experienced, and there were fewer hospitalizations. So, of course, the pandemic may have played a role. But also, the availability of ETI is another possibility. And you would think if it was just the pandemic, you might have seen a drop in 2020, but those numbers would have increased over time. But of course, you can see from these graphs that the numbers continue to decrease. And actually, in the Canadian registry, in the last year, there were only 7 transplants done in the entire country, which is our usual rate is about 50 in a given year. So let's look at the impact that ETI has had in the cohort of individuals who have advanced lung disease. And this is a paper that was published in JCF in 2022 using the French data. So they had a compassionate program identifying 65 individuals who were started on ETI. 17 of these individuals were actively listed for transplant, and 48 were considered for listing within the next 3 months. So they were obviously at high risk for moving on to transplant. And they were followed for up to 1 year. Now, 2 patients died after the initiation of ETI, but I will point out that that was fairly early on, transplanted, not died. They were transplanted after the initiation of ETI. One was 5 days after starting the medication, the other was 9 days after starting the medication. So you could argue that the medication perhaps wasn't enough time for it to see the full effect. But they followed the remaining 63 patients over time, and this is a figure from the paper. This is the number of patients on the y-axis and time on the x-axis, and the gray bars represent people who were considered for lung transplant, and the black bars represent people who were actually on the transplant list. The white portions of these bars represent people no longer meeting the criteria for lung transplantation. And you can see that over time, the proportion of people that no longer met the criteria was increasing in this cohort of people started on the medication. Looking at other outcomes, this is showing at the top left-hand side, FEV1% predicted, the change in FEV1% predicted in this cohort, and the bottom left is showing the nutritional status and the change in BMI. And we can see that there is an increase in even people with advanced lung disease in this cohort that's sustained over the 12 months. Similarly, the weight increased, and on the bottom right-hand side, you can see the proportion of people on IV antibiotics as well as hospitalizations. Those also decreased in this cohort. Also looking at other outcomes, long-term oxygen therapy decreased over time as well as non-invasive ventilation. So clearly this medication in this individual group of people with advanced lung disease moving towards transplant had a significant impact. Now, this was one country in France. Maybe there was something unique about that particular situation, but there's other studies that have been published, a similar experience in Spain, where they followed 114 people with advanced lung disease up to 30 months, and they too also looked at other outcomes, but they commented that there was a significant proportion of people that no longer needed oxygen therapy and a significant number of people who were taken off the transplant list. And most recently, there was a publication using the US CF registry in over 16,000 people. So this was across the spectrum of disease, not just people with advanced lung disease. And they followed people for 20 months. Again, this paper talked about various outcomes of ETI. But in this table, they comment about deaths and lung transplant in the cohort using this medication compared to a historical control of 2019. And you can see the circle shows that there was a 72% reduction in deaths and 85% reduction in lung transplantation. So again, I think that there's convincing evidence that this medication has impacted the transplant rates over time. So the question is, will transplant actually be needed in the future? Is this something that's going to just continue to decrease and won't be a significant treatment for people with CF? And I would say that that's not the case. There are scenarios where lung transplantation will still be required despite the availability of ETI. First of all, there's people who aren't eligible for this medication, and those people may need to move towards transplant. But also, we don't really know whether or not that improvement and remaining off the list is going to be sustained for one's life. So it may be that people require transplant, but not until much later on in their life. And we don't know if ETI is going to stop the development completely of structural lung disease. So if it's used early on in life, are people not going to develop lung disease to the point where they would actually require a lung transplant? We don't really know the answer to that quite yet. But if we look at the literature showing the rate of decline in lung function for those people on ETI, there was a nice paper that was published this year, and it followed 468 individuals on ETI and compared this to a propensity-matched control group. And they measured lung function for up to 120 weeks. And they excluded the initial improvement in lung function in the first 21 days because we know that after starting the medication, your lung function often will increase. So they didn't want that to contribute to the rate of decline over time. So they didn't start looking at the change over time until after that 21-day period. And this is a graph from that study showing the two groups. So one group treated with ETI and the second group is the control group on the bottom. And you can see that the light blue line, first of all, is higher than the dark blue line. And actually, over a 2-year period, the gap between those two groups actually is increasing, suggesting that the rate of decline is different between those two groups, decreasing in the control group and remaining relatively stable in the people treated with ETI. Now, of course, this is only up to 2 years, so we don't know the long-term effects. So who is actually moving forward with transplantation now? As I mentioned, some people are not eligible for ETI. Certainly at our experience in Toronto, those are the individuals who are still in hospital and moving towards transplant at times. I mentioned in the French study, there were some people who were transplanted despite starting ETI. And in the Spanish and US study that I talked about, again, there were some people who were transplanted despite starting this medication. So in preparing for this talk, I actually got some preliminary data just from the US, Canada, and UK to share with you, just summarizing the number of transplants and the characteristics of some of these individuals in 2020 to 2022 compared to a previous year, 2019 for Canada and the US and 2018 for the UK. So the first thing to note is over a 3-year window, the number of transplants is less than a 1-year time period for all of these countries. So clearly there are not as many transplants, which we saw in that first graph that I showed. But also the interesting thing is just the changing characteristics of some of these individuals. So you can see that genotype, for example, as you might expect, fewer people are being transplanted who have at least one copy of Delta F508. And there's an increased proportion of people who are being transplanted with other mutations. And why is this important? Because these individuals potentially have different survival after transplant. They may be at higher risk for complications after transplant. So you wonder if some of the information that we know about prognostic factors may not apply to this new cohort of individuals who are moving towards transplant. The other thing I'd like to point out is that ETI in the transplant year, if you look at that row, of course, nobody was on ETI before, but there are people who are on ETI, and these are proportions in the most recent 3-year window. So people on this drug still sometimes do progress to require a transplant. And the other thing to note is that the retransplant proportions is going to increase as well. So we have a cohort of individuals who have already received a transplant, and those people may go on to develop chronic rejection or CLAD and be needing a second transplant, sometimes even a third transplant. So I think those individuals are going to be people that are moving towards transplant. So the take-home message here is just the characteristics of transplant recipients are changing. ETI does not completely eliminate the need for transplant. So now shifting gears, I want to talk a little bit about some of the outcomes, specifically survival after transplant, what we know in the literature. So these are two graphs just highlighting a couple of papers, one on the left-hand side, which is the ISHLT graph, and CF patients are the topmost line compared to people with COPD or pulmonary fibrosis. And this is a survival curve on the y-axis. This is the proportion of people surviving in time since transplant on the x-axis. And you can see that CF patients do very well compared to other lung diseases. And the median survival after transplant was 9.9 years, so almost 10 years after transplant. Now, obviously, you're referring somebody for transplant. You're not expecting that they're going to live on average 10 years. So hopefully, the transplant will be beneficial for those individuals. And if they lived that first year, the median survival was even longer. So they got through the first year, the median survival was 12 years. On the right-hand side is a paper that shows basically the survival in some other countries like Canada and France. And this is looking at the 1, 3, and 5-year survival in these two countries. And you can see from the graph they're quite similar between the two countries. And the 5-year survival is over 70% in both France and Canada. And in fact, we couldn't calculate the median survival because those curves actually didn't cross the 50% mark yet. Now, what are the pre-transplant predictors of post-transplant survival? And there was a nice systematic review that was published in 2019 and did a literature search up to 2018. And these were some of the variables that were highlighted in this review, showing that people with Burkholderia cepacia, not surprisingly, have an increased risk of death after transplant. The year of transplant was protective in that if they were transplanted more recently, they did better than if they were transplanted a while ago. And older age at transplant and male gender had borderline significance. Some of the other factors that they looked at in this paper, like lung function before, like going into transplant, nutritional status, et cetera, were not significant predictors of mortality in this systematic review. Now, since this paper was published, there's another paper that has been published by one of the chairs here, Dr. Clausen, who looked at the impact of genotype on post-transplant survival. And we can see from this graph that if you have a high-risk genotype or other genotype, defined as 2 copies of class 1 to 3 mutations or others not yet classified, you had worse survival than people who had at least 1 copy of class 4 or 5 mutations. And I think this is important because of what I showed you in that initial table. The people that are going into transplant now may be more of them have these high risk or other genotypes, and their survival actually won't be as good as what we quote as the median survival after transplant using older literature. Moving on, this is 2 studies that are looking at individuals who are post-transplant, but having a second transplant. So I mentioned also that there will be a larger group of people that are going towards second transplant. The graph on your left-hand side is a paper that was published in 2022, and the 2 lines show the darker line is the first transplant compared to the survival if you're going in for a second transplant. And you can see from the graph that if you're going in for the second transplant, your survival is lower and you're at higher risk for worse survival after transplant, which is not terribly surprising because it's a complicated procedure. There are more risks involved, bleeding, et cetera. And on the right-hand side, this is a combination of Canadian and US data using the registry that was linked to UNOS, basically just showing the survival. Median survival time after second transplant was 3.3 years. Remember, I told you that median survival after the first transplant was 10 years approximately, or 12 if you survived that first year. So clearly, the second transplant is a higher risk for death. Now, moving on, I wanted to spend the last few slides just talking about the use of ETI after lung transplant and what we know about this. This was a study that was published by one of my colleagues who's speaking today, Dr. Ramos, who looked at 14 different sites, transplant sites, and asked the question of, are people receiving ETI after transplant? And this figure shows on the x-axis the lung transplant programs, and on the y-axis you can see the bars represent the number of transplant recipients followed at those centers, and the dashed lines represent the proportion of people who are prescribed ETI after transplant. So the first thing is the rates of prescriptions of ETI after transplant is highly variable, ranging from essentially nobody to some centers where 35% of individuals are prescribed this medication. The most common reason for prescribing it was sinus disease, followed by GI symptoms in the hope that that would improve their symptoms. But the interesting thing is that 42% of patients actually ended up stopping ETI either due to GI side effects or a lack of perceived benefit of using this medication. And there were possible benefits that were highlighted in the study, and I'm not listing all of them, but there was a suggestion of improved hemoglobin A1C in people who were started on ETI, and also a reduced number of antibiotic prescriptions in general in this population. Now, one other paper I just want to highlight also from Dr. Ramos's group, but they basically sent out a survey to get the perspective from the individuals who are the lung transplant recipients. What do they know about ETI, and what was their perspective? So they sent out this survey and 46 lung transplant recipients responded. It seems that people obviously are aware of this medication. They're interested in the potential that it might help with extrapulmonary side effects or issues related to their CF, because clearly the lungs are no longer having CF, so it really, there has to be a benefit outside of the lungs. But there was concern about drug-drug interactions with using this medication, side effects, cost, and lack of clinical trial data suggesting or supporting its use. And over 50% said that they would consider using ETI if it was recommended by a CF or transplant physician. So I think in the future, we have to be aware that these questions will come up in clinic asking us about whether or not we should recommend or the patients should take this medication after transplant. So in conclusion, I just wanted to say that in general, there's a significant reduction in the number of lung transplants in the era of ETI, and the characteristics of those lung transplant recipients are definitely changing. And we need to be aware of that, because when we talk about outcomes after transplant, it is a slightly different cohort that we have data on from previous literature. And also, I think there needs to be continued research on the role of lung transplant in CF, what the outcomes are like after transplant in that group, and the role that ETI may play in post-transplant lung transplant recipients. And with that, I will thank you very much and happy to answer any questions.
I just want to mention that we are live streaming, so we will have some virtual questions coming in from people watching from home. If you do have questions, you can either use the app, or I've experienced some delays with the app, so I guess I'd encourage you to come up to the mic and ask questions, because we might miss them through the app. So if there are no questions from the audience, we'll start with a couple from virtual attendees, if you want to.
Sure. There's one virtual attendee has a question about taking out biological lungs. Would any infected mucus in the remaining airway nasal cavities cause infection to the new lungs?
Yes. I will say at the beginning that I am a respirologist and not a lung transplant physician, but yes, definitely you take out the bulk of the infection when you remove the lungs, but clearly there's the main airways, there's the sinuses, and those bacteria that are in there can get back into the lungs that have been transplanted. And that's why the first year is quite, there's risks associated with that first year, because you're on fairly significant immunosuppression during that time period, and so your risk of having worsening infection is increased. And there's some studies that have looked at giving antibiotics for things in the sinuses, and that's why the sinus disease is considered important in trying to prevent those infections later on.
I wondered if, so Dr. Ramos had a talk yesterday and talked about the aging CF population and made a good point that just because some of our patients are improving on ETI and no longer needing transplant now, that it may be a disservice to them to not let them know they could need transplant still later. Mm-hmm. Do you have any thoughts on next directions for looking at people that may be on ETI that need transplant later, and how that should affect our guidelines?
Yeah, I mean, it's tough because we don't really know, as I showed in the slide. It does seem that the lung function trajectory is quite flat, and it may be that people never get to the stage where their lung function is so decreased that transplant is an issue, and they may actually die of other causes and have other complications that have nothing to do with, needing a transplant. So it's hard to say. I think we need more time, but I will say that given the literature so far, it seems that ETI does improve things, but it doesn't mean that you're not going to have a transplant. And also there's a different population of individuals, because we have a cohort of individuals with structural lung disease that are started on these medications, and how that's going to play out. If someone has very significant structural lung disease and they're 30 years old, even on ETI, it may be that there's progression of their lung disease, and then when they get to be 40, 50, 60, they may have a state where they need to have a lung transplant. But if you start medication and prevent that structural lung disease, that's a different scenario. And in those circumstances, yes, maybe it's going to be way down the road. So I think people still need to talk about lung transplant with patients who have low lung function or recurrent exacerbations, and all the same things that are in the guidelines to identify high-risk patients. And having the conversation doesn't mean someone's going to be listed for transplant. You just are having the conversation, talk about it, say what we know and we don't know, and I think patients would appreciate that as well.
Go ahead.
Thank you for a super talk. Lots of things to think about. I'm Andrew Prale from Nottingham. We're currently updating the Cochrane review about on various aspects of things, and one of them is about transplantation and in particular looking at the impact of bacteria such as non-tuberculous mycobacteria and how that, because it varies from centre to centre, whether those patients who are infected with NTM are considered candidates for transplantation. I just wanted your thoughts on whether ETI and so on impact on that decision making.
Yeah, I mean, I think that the microbiology within the lungs is changing also with ETI, and it's hard to know, what the full impact of that's going to be, whether or not that's suppressing certain bacteria. And I think it's variable depending on the center, whether they transplant people with NTM or abscessus in particular, and also the degree of burden of disease that people have. They may have NTM, but it's not smear positive, so those people might still move forward for transplant. So I think that the next few years is going to be very important to see how these drugs change the microbiology within the lungs. And again, thinking about the risk factors after transplant, we don't really know what those are going to be like in the setting of ETI.
Thank you.
Joe Polisky from Pittsburgh, I'm sorry. And that was terrific. I just wondered if you could elaborate a little more on the listing decisions and how, as a respirologist, you might view them for somebody on ETI and not on ETI. I guess I'll project that I've always thought, or very recently thought, that it's a different population, really, very different, and that those on ETI are oftentimes faced with a decision to proceed with transplant that's based on quality of life decisions as much as it may become that way as much on survival. Whereas those not on ETI are probably pretty clearly, at the time we list them, are going to gain survival advantage. Do you have any thoughts about that or how you approach it?
Yeah, I mean, again, I think it's difficult to know how things are going to play out, but certainly on these medications, people's quality of life has improved substantially, despite we have lots of patients whose lung function really hasn't changed too much, but their quality of life has improved, and they are not thinking at all about transplant. Even though when I look at their lung function, I'm like, oh, okay, or maybe a lot of people came off oxygen, but some people stayed on oxygen. So I think that it will be a combination of our usual metrics like lung function and pulmonary exacerbations, but also the quality of life will play more of an important role in that decision. And I feel like it's all about conversations and taking people at an individual level. It's so hard to sort of make sweeping generalizations about patients. You really have to sort of see that person in their individual situation and talk about what they want out of transplant. Yeah.
That's terrific. Thanks very much.
I think in the interest of time, we're going to move to our next speaker now. Thank you, Dr. Stevenson, for a great talk. I have the pleasure of introducing our next speaker, who's also a former mentor of mine, Dr. Patrick Smith. He's a clinical health and neuropsychologist, associate professor of psychiatry at the University of North Carolina at Chapel Hill. His prior work has focused on the use of biobehavioral interventions to help people build resilience to cope with chronic medical conditions and to improve lifestyle habits. He has previously served on 2 International Society for Heart and Lung Transplant consensus committees for the evaluation of heart and lung transplant candidates, as well as the Cystic Fibrosis Foundation's 2019 referral guidelines. So please welcome Dr. Smith. He's going to discuss with us today mental health considerations in the CF lung transplant.
All right. Thanks so much for having me. Let's see here.
You can.
Nice. I think so, yeah. All right, great. So just put my disclosures real quick. And I just wanted to say thanks to a bunch of the colleagues who've worked on this work together. I would also want to say just thank you all for having me at this conference. This is my first time at NACFC. And I think this has got to be in terms of actionable information and just like really nice, kind people, might be the best conference that I've been to in terms of just really kind people. Yesterday, so I'm going to be talking a lot about behavior, so I'll give you one kind of clinically relevant behavior. I was out there drinking coffee yesterday, and a woman about this tall, shoulder-length blonde hair, green shirt, the staff member couldn't get the table out for had the breakfast stuff yesterday. She walks by, stops, goes back, offers to help her clear the whole thing sort of off. It's like the nicest people. So thank you all for having me here. It's not all, and they're not all Canadian. I mean, everybody's nice. It's great. So what I was going to be talking about was I figured most of the research that I've done has either been sort of from clinical evaluations or clinical interventions with patients, and then also doing sort of the analyses of randomized trials that are doing kind of coping skills training for people who have chronic medical conditions, COPD, chronic heart failure. And so what I was hoping to do is kind of, I'm going to jump back and forth a little bit, if this is okay, to kind of give you some bridging of kind of clinical, where I think the clinical intuition matches up with what we have in terms of empirical data. Because the CF community is, and I think this has already been kind of touched on, but you can't drive it home enough, everybody's different. People have very different kind of needs and are coming to this from different places. And so it's not a monolith. You can't kind of treat everyone in the same way or kind of make, broad statements about what people are going to need. So I'm going to try to show you some examples from the data that we have and also link that back to relevant clinical information. Okay. So the reason I'm going to talk about coping is it's probably at least from my standpoint as a behaviorist, it's one of the major things that you can change that tends to track with how people are doing, how they're feeling. It's something that's actionable. It's almost like a biomarker, but for your behavior. It's the kind of thing that's predictive of long-term clinical outcomes. You can modify it. So it's a really useful kind of barometer for how people are doing. There's different ways of sort of thinking about how somebody's coping, and oftentimes this is just stuff that we're doing day to day and we don't necessarily kind of give much thought to, but there are things about how we approach sort of different strategies, approach fixing a problem, maybe how we sort of help calm ourselves down. There's also kind of a profiles of coping behaviors. So for many people, you don't cope in one way. There's a diversity of things that you do in different situations to help you get through the day and be sort of effective. And one thing that's hard to operationalize is that kind of coping flexibility over time is probably an important predictor of how people do in complex situations, because you need multiple skills to navigate the different aspects of the challenges you're kind of going through. So it's not as simple as saying that this person's really organized, they're going to be great with transplant. That's great for many pieces of transplant, but that's not everything that you are going to go through. And so appreciating that you can have these sort of profiles of folks where this part's going to be straightforward for you, this part is going to be new and might be a challenge, and that's going to vary across people. The only other thing I was going to say was that you can also think about kind of habitual versus sort of situation-specific responses. I can't tell you the number of people that I've had when we're doing evaluations for transplant where they seem great and this happens actually more in IPF than it does in CF, where the person's had a really long, successful life. They can kind of clearly cope very well. They've never been in this situation before. They've never felt this way. They've never gone through this specific thing. So kind of the context demands are really different, and it's just harder to predict. Many CF folks, when you think about what they're going to do after transplant, they're like, I got to manage some medications. Like, yeah, I'm good. That's like, they've already done so much of the things that you're going to need to do afterwards. So thinking about, have people been through this before, and was it sort of similar enough? So to give you just a couple examples to drive these home for kind of coping, the skills that you need to kind of approach a chronic illness, maybe exercising, changing your diet a little bit, learning more about what you need to do for your disease, that's one thing. If you're like me on the plane over here and you're stuck next to a crying baby, your organization or sort of ability to problem solve is not going to help you that much. You're stuck there, right? It's kind of like, so you have to have, it's a different skill set. You have to be able to kind of like distract yourself, lower your arousal. Some people can do one really well, some people can do the other very well, and they're not necessarily the same people. So thinking about, you might need multiple skill sets to make it through, the world, and kind of knowing when to use different things. I love these demotivational posters. I hope people are okay with a little bit of sarcasm. And also being able to kind of know when you would want to use different skills. It's great to persevere and be very, consistent. I always, for people who know the neuroliterature, you want to persevere but not perseverate. There's a point at which kind of doing the same thing and pushing through is not a good idea. Just to give you one more metaphor, there's a lot of rivers in North Carolina that are great to kind of kayak on. So just to give you an idea, if you're paddling on a flat surface, the amount that you paddle is going to get you further. So the amount that you're putting in is going to get you further. It's a pretty close relationship. When you're going through rapids, for people who've done this, you're holding your oar up. You're not doing nearly as much because steering more is actually going to be worse for you. It's going to get in your way. So you need to exert some control, but actually exerting as much control as you did before is a bad idea. And if you're in the kind of the highest level of kind of demand, your best move is actually to do almost nothing and kind of like just wait until you're back and sort of stable again. Does that make some sense? Going through the transplant process, for many people, is a little bit like this. You're not in control of what's going on when you're on the operating table. Many people worry about that kind of situation. So there's parts that you can really control, there's parts you can't, and it's trying to get people used to what they can control and when. This is not a new idea. So for people like Aesop's Fables, I've been reading this to my youngest daughter recently. There's this older story that's the mighty oak and the humble weed. So a really strong oak tree. It's great, doesn't like the reeds, talks a lot of trash, and then eventually a really, really strong storm comes and is such a strong gale that ends up kind of blowing over the tree. The reeds, because they are so flexible, can kind of like hang with all the changes that are going on. I think the only other thing I'd kind of say, I think people kind of know this, that you kind of need different skill sets to get to the same goal. The other one that is much debated down where I live, and between Duke and UNC, is you can have quite different personality temperaments to get to quite different sort of successes in terms of coaches, right? So like you can have very different sort of profiles of personality, profiles of behavior that might ultimately be sort of lead to success, but you're going to have different people are going to need different things. It's not going to look the same for everybody. There's not nearly as much data kind of looking at coping specifically in cystic fibrosis patients, and I'm going to talk a little bit more about kind of how we think about coping or how to kind of measure this, because it's a little bit tricky. But there's at least some data kind of looking at overall survival in CF patients, and with the idea that people who are more actively coping, which they've used optimism here, but people who are more engaged, doing more to take care of their care, do better in the long run versus people who are more avoidant, kind of like don't want to think about it. It's a little bit too upsetting. In transplant candidates, one of the first studies that I was ever on was back in 2008. I was a graduate student. I'd never seen any transplant candidates before. I was working with secondary data. And we had this interesting finding. This is in the pre-LAS area. This is a while back. But we were looking at coping and quality of life in lung transplant candidates. And these are folks who are on the wait list. They're kind of waiting. And there was this interesting finding. Typically, if you are doing more things to take care of your care, that's good. If you are avoiding it, that's bad. And for most people, we found the same kind of relationships. If you're actively coping, that's kind of good. You feel better, you're less depressed. If you're avoiding things, then you're more anxious. For CF patients versus some of the other patients we had, like COPD, it wasn't exactly that simple, especially for sort of physical health. So some of the CF patients in particular, who were in a really different context in that pre-transplant waiting period from COPD patients, for many of them, I think they had never felt that bad or sort of decompensated. So their act of kind of like coping with what's going on may have actually been either getting in the way, or their perception of that relationship was sort of different. But it's clearly a different relationship than what you usually see in that subgroup of patients. Okay. So I hope I've convinced you this is something that's like reasonably important to kind of care about, but it's a big driver of compliance. One of the things that tracks the most sort of with mood. I would say from a transplant standpoint, part of the reason that I think about coping a lot is because if somebody comes in and they're really anxious, or they've got some other kind of mental health concerns, what you really care is, are they doing the thing they need to be doing? Like, what's the target behavior? Are they taking their medications? Are they going to appointments? Are they making the adjustments they need? If they're doing all that stuff, I don't care nearly as much about any of those other kind of considerations. I worry about things like depression, anxiety, personality features, in so much as they are related to you not doing what you have to do. Does that make some sense? So if I have people come in, and this happens in particular for folks who are more anxious, it might be a problem, it might not. It has to do mostly with, are they avoidant? So it's really the coping piece of that leg. If they're not that avoidant and they're just kind of angsty, that's okay. They may be perfectly fine. That might actually help them do better in the long run. So it really is about not ignoring, like, what's the behavior you're interested in? Are they doing that thing? So I don't know if people like James Carville. I always think about this, the Clinton strategist. It's the economy is stupid. It's the behavior is stupid. Just always think about what's the target behavior and are they doing that thing? And this is if you look at the consensus guidelines that have been on the past few years, this is kind of, amidst the other stuff that's in there, it's always kind of goes back to that. Are there people kind of doing the behavioral pieces that they're supposed to be doing? Let's see here. The other thing that I think is kind of worth mentioning is that the importance of coping kind of varies across the phases of the transplant process. So my colleague Lily Christland and I did a review after the last consensus guidelines. It was looking at kind of different parts of the transplant process and when you're going to have some of these behaviors have a more relevant impact. And you can see some of the arrows all kind of like funneling to the same kinds of places, which are mostly about, are you maintaining adherence? Are you doing okay? And then one of the big places this varies, or where you see some kind of dynamic relationship, is that not everybody has the same clinical course following transplant. So it's not a monolithic, and everybody who's dealt with any patients knows this. Some people have more complications, some people will have rejection. The challenges you have to deal with after transplant are not the same, and you don't necessarily know what that's going to look like beforehand. You might have some idea, but for people coming out, you can be the best coping person in the world. If you have a really rough postoperative course, that's going to be harder. You can be somebody who is not particularly good at kind of coping, you're kind of marginal, and you sort of breeze through and have an easy clinical course, you're probably also going to be okay. So it's a tricky kind of dynamic, but I think that if you think about it in that way, where not going to be the same for everyone, you might even think about identifying people who are at risk by what is their burden afterwards. If that's really, really high, then they're going to have more likelihood of having a difficult go. So some of my colleagues and I, Dr. Hare included in the audience here, we have been looking at kind of like what are the different kind of profiles of how you can best help people to kind of get through the process. Part of the reason I'm mentioning this, and I'll show you like some data about this later on, for many of the CF folks that we have, their coping sort of style is different from most other people who are going through the lung transplant process because their life experience has been different. For many of them, we think about most people who have a chronic medical illness as being kind of under control, like they're not keeping their stuff together as much as they need to, they're not on top of what they need to be doing. That's not so much an issue with CF folks. They have kind of come through this life experience where they're on top of things. The difficulty is letting go or kind of like having periods of time where there is more uncertainty as to what's happening to them in the transplant process. I think that's probably fair to say. So it's a little bit more what you'd think about as over control, which is a different clinical entity and something that you treat differently than folks where you're trying to kind of build them up and get more organized. Does that make some sense? Okay. In a lot of our work, we have pretty consistently found things like depression, physical activity, sort of different behavior components being related to long-term clinical outcomes. When you look at these kind of together, though, and you kind of piece out some of the relationships, much of what you're seeing between things like depression and other kind of outcomes is are they doing the most relevant behavior? So if you take into account physical activity, that takes out most of the variance for like depression sort of being a risk factor for sort of predicting. So it's mostly about what the person's doing. Probably maybe not entirely, but when we think about mood kinds of risk factors, again, kind of coming back to the target behavior. One of the tricky things about coping in general, there's a little bit of this sort of streetlight effect. I'm not sure if people are aware of this sort of source of bias, but it's like, guys outside, is this where you lost your wallet? No, but this is where the light is. So we tend to go to things that we know how to measure and that we feel comfortable measuring. There's a plethora of behavioral kind of compliance sorts of data that are imperfect, but sometimes useful, like in EMR that kind of like people have clinical experiences with. I'm sure that people have had, I can't tell you the number of times I've called folks providers because they've been following over years, because that person can give you exquisite information usually about the person's compliance that you can't really reflect in a self-report measure, right? But there are some sort of useful barometers, and I'm saying barometers because this is a little bit like temperature. It's not perfect, it's not exactly the thing that you're kind of looking for, but as a broad category, it reflects what you're trying to kind of get at in terms of changes. So if people have not seen these before, these are things like self-efficacy, so like basically your confidence in a particular area. Coping styles we've talked about. Psychological flexibility is a big one. I think that's kind of emerging as an important characteristic, as an important area, kind of a mechanistic factor. The other one I was going to say, and this is the clinician in me talking more than the biostatistician. People are familiar with emotional granularity. If somebody's talking to you and they can actually give you how they're feeling in exquisite detail, and it's this, not this, but in kind of like this more sort of integrated way of describing how they're doing, their emotional insight's better. That's a great predictor of someone's coping ability. I mean, it's not the only thing, but it's one of these sort of clinical signs that is it's useful in terms of how the person is doing. The other thing I'll just kind of mention, I'm sure people have seen this, but for many folks with CF, their kind of profile of coping and confidence stuff is very much this sort of old soul kind of profile because they've been through a lot more than other people have. And because they've been through that stuff, they also have not been through some normative things that other people have. So they have this like depth of life experience. It's more complicated and also different than a lot of their sort of peer. Does that make sense? Yeah. So there's an interesting sort of, they have a depth and sort of, they've been through things that many other people won't go through their entire lives. And they have also had in some cases, some delays or sort of missed opportunities because of their care. So it's a very different sort of like psych profile kind of coming in where they have a greater depth and a lesser depth of experiences at the same time. Okay. Make sure I'm doing okay on time here. Let's get that just for a second. Give you. Before I talk about some of the qualitative stuff, and I think Kathy's going to talk more about this, but I want to talk a little bit about some of the qualitative data with CF patients. But I wanted to just acknowledge first, every CF patient is going to be different, and I think I think it was well said before that you want to approach people individually. My favorite one of these quotes that gets at this is there's this statistician George Block who passed away this last year, who would say all models are wrong, but some are useful. Which is basically how I think about doing a lot of the research that we're doing. It's never going to be perfect, but sometimes it is useful in terms of getting at themes that are kind of common across people. So for our qualitative data, think about it in that way. It's not going to be perfect, but identify some themes. Or if you're a Ted Lasso fan, every person's a different person. And at the same time, there's usually themes that are consistent enough that it is sometimes useful to have ways of understanding patterns of behavior. So in our qualitative data with CF patients, when we're looking at them getting to transplant, some of the themes that were identified in terms of barriers or things that would get in their way or their experience with the whole process were things around the timing, the accuracy of info. I'm not going to get into these in detail, but just to kind of give you a few different kind of flavors for what that looked like. So I wanted to talk for a minute about how this intersects with what's called decision balance. But folks, we were talking a minute ago about having conversations about transplant and getting folks to that, which I think is really important. And it's interesting because many people, I think that bottleneck, getting people to the process where they're doing the evaluation, can be tricky for different reasons across different people. So for many people, when you're thinking about a big decision like this, you're sort of like, you're thinking about what are the positives, what are the negatives, what is the risk of doing nothing. Obviously with our transplant patients, this is kind of changing because of the new, pharmacological interventions that we have. But there's the same kinds of issues where you're sort of worried about them delaying their care, avoiding it. For many people, part of this is, I think it's fair to say, is transplant has very different meanings to different people. In the same way that, like, if I said pandemic to you, or vaccine, or you can imagine for different people, that's going to really, there's an emotional underlay to that might be very different across people for their own personal reasons. And if you don't unpack that, you can be talking right past people that have concerns that are partially to do with what you're talking about, but more to do with some of their life experience that precedes that. Does that make sense? I can give you one example of this, just because I know this one well. So my uncle a few years ago was up for a bone marrow transplant evaluation. And he's just like the nicest guy you'll ever meet, super, super patient, inexhaustible Civil War knowledge. Apparently there's like a Civil War magazine you can get every month in case people, I don't know if anybody gets it, but he did. So great guy, but nothing clinical about my uncle as far as I know, not depressed, he's just very passive guy, most patient guy you'll ever meet, probably the least self-advocating person that I kind of know. So in his case, it's kind of ambivalent about going through this thing, delayed the sort of evaluation process. By the time he got in the door, it was too late. He missed his window. And so this happens a lot, I think, with some of the CF patients that we sort of worry about, is that ambivalence or not kind of knowing what's going to happen if I do nothing, what's the risk of the status quo? And thinking about kind of like how you can get people motivated during those kind of critical periods. Some of the data that we've been looking at most recently in CF folks, I think, kind of supports this idea that there may be a tendency to kind of over control. So I'm not going to get into this in a ton of detail, but in one of the trials that was presented earlier this week, CF patients sort of at baseline had a strong tendency to be over controlled versus under controlled. So they're much more likely to kind of like want to control what's going on in their life versus sort of just going along with things. And when you look at how things like grit and psychological flexibility and over versus under control styles kind of went with how they were doing overall, flexibility was probably the strongest correlate of them, having lesser depression, lesser anxiety, even when you control for things like grit or over versus under control. So not that those other things aren't important, but it's also important to be flexible at times as well. All right, let me just wrap up. I was going to just give a couple clinical examples that I found with patients as they're going through the process when they were sort of more either ambivalent or you're trying to kind of get at that decision balance sort of period. One of the things that I have oftentimes done for people when they're trying to sort of assess their own risk, we have risk calculators and other forms like that where you can kind of get it out of their head and how they're thinking about it to something that's more of a numbers thing. So like if somebody was in Vegas betting on your outcomes, or if you're in front of a judge, something that kind of operationalizes, not how you feel about it, like give me something that's more of a brass tack kind of a number. There's a saying in the motivational interviewing literature, if people haven't heard it, that if you act like you have 5 minutes, it's going to take all day to get the information out of somebody. If you act like you have all day, it's going to take 5 minutes. So going slow with people, being patient, giving them a little bit of time to sit in the discomfort that they may have when you say, so you might want to do a transplant evaluation. It's a little bit like if you were to say to somebody, when you start talking about cancer for the first time, they're not going to hear the next few things that you say, right? If you can't sit in that discomfort, you're never going to get to something actionable behind that. Skip ahead in the interest of time here. And lastly, I was just going to say, one of the things I was really encouraged from this week, and this is partly related to the transplant sort of window time period, but also just more broadly with cystic fibrosis patients, is that there's a lot of, I think, really actionable data that's out there that's sort of really encouraging. A lot of these we've got several different interventions that were presented this week. They're like 6 to 8 weeks in duration that are very trainable, where people got a lot of benefits out of them. And for many of the folks that were in these studies, I was struck by how many people had either already done therapy or were in therapy or were on psychotropic medication. So they're being actively involved in kind of managing their distress. Let me just finish up because I think I'm over time. So for the CF patients that we're kind of seeing, one of the things I always emphasize, they're sort of the rock stars of transplant. If they need to do it, then it's, if it's life-saving if you need it. When you're evaluating folks, don't forget about what's the behavior you're sort of looking for and why. And think about kind of two-pronged approach. Think about kind of like, having people where they're kind of like, they're building up, being more organized, kind of, on top of their care, and sort of cultivating some skills for them to be accepting of there's going to be some twists and turns along their course, and that's okay. And with that, I can stop for questions. Thanks.
Thank you. So we're open to questions. But while we're looking at the virtual questions, I have a question. Is there an effective way to impact folks' coping skills? I mean, are there ways to train to improve their coping, improve their resilience?
Yeah, there's a ton. Yeah, there's a lot of, there's a lot of manualized interventions and stuff. I think that in CF specifically, they have some different challenges in that we know how to do that at kind of a broader level. It's just, I think it's been translating into the CF community because there's some of their life experiences are so different. So I think that I do like some of the ACT stuff that we've been, I know I'm on some of these sort of studies, but to me that those kind of acceptance-based therapies make a lot of sense because you have part of the chronic condition that you can't control. And so for treatments like that, whether it's like, there's other conditions that applies to as well, some diabetes, some kind of forms of HIV. But I think that that kind of approach where there's a piece to kind of building up sort of resilience in a traditional way, but then with it where there's some nuance for CF folks' experience as well.
Thank you.
Well, thank you for your talk. I think one of the things to me I wonder about is sometimes when we're doing transplant evaluations, these questions around adherence and coping sometimes feel like some of the most subjective aspects of our transplant evaluation process. And I think something I worry about is like, is that a source of implicit bias for us as providers? And I'm just curious sort of like if you think there's any role for some of this coping research to help with health equity in the transplant process. And,
And no, I think that's a great question. I think so. I think that it's, especially for compliance data in particular, it can be so tricky because it's so context specific. But I agree with you. I mean, I've had a number of patients where there's somebody concerned on the team about them having some adherence concerns because of some interaction they kind of had with them. And then trying to think kind of rigorously about if there was an issue, where would I see this show up in these other metrics that I have? So we oftentimes will sort of use these sort of, we have multiple different sort of softer proxies for this, like how many appointments are they showing up to? Is their FK level within the right range? Their weight change. There's a bunch of different things that are imperfect, but kind of if you look across those and everything seems kind of airtight, I'm much less concerned about what their self-report is or kind of like how they came off in an interview. But I think operationalizing that or making that sort of, it's tricky because it's just it's a little bit elusive because it's going to look so different for different people. We oftentimes at Duke, when I was there, would look at how people were doing with pulmonary rehab, in part because we knew it was being delivered the same way it was the same context. So you could actually see people going through the same thing and kind of how they all did, and it kind of gave a fair comparison in some way. But I agree, it's an important area, and I don't think it's been developed quite well yet.
Thank you.
Thank you for your talk. One question that I have is, can you comment on the effect that age might have on this? And whether there's, basically an age where things might be a little more set and difficult, to change versus the person that's, still a teenager or a very young adult from our perspective?
Yeah, that's a really good question. Yeah, I think that I guess my impulse is, I don't know that anybody's actually studied this that rigorously. There are aspects, some of the things you get out of these behavioral training paradigms, there's no reason to think that it would change with age. I mean, it might, certainly more your personality is formed by the time you're, when you're in your 20s, but some of the things you're learning are really more skill-based. So like it's going to look, I think what is sort of formed by the person that's not going to change can impact kind of what's going to resonate with them, how you deliver this, like what are the skills that they might be more interesting to them, but they're still going to get something out of it, I think. So it's a great question. I think in some ideal world, it'd be nice. I mean, the skills you learn in this are the kinds of things getting through your teenage years. It'd be really nice if everybody got something like that, like learning how to regulate yourself better. So in some ideal world, I would say targeting teenage years in particular is a great time because it's an emotional roller coaster, and that's a perfect time to learn those skills.
You have a question?
No, go ahead.
It's making the transplant decision, sitting on the transplant committee and saying, is this person a good candidate or not a good candidate? You say, well, they're not very good at coping, but that's not enough not to transplant
Right.
them. Once you've transplanted the person that's not so good at coping, are there approaches that you can take to try to get them through the hard times?
Yeah, I think that's a great question. So I think the figure that I sort of showed that had the kind of over control, under control thing, part of the reason for me, this is a conceptual framework that it's getting published. I guess it's in the proof stage. But the part of my thinking with that was, I think that I don't know where exactly that sort of threshold is, but at some point you start to look external to the person and kind of try to build up more of their sort of support network around them. I think that people who are, I think about this as being sort of like, it's partly an individual risk and it's partly sort of a systems risk with their level of support and the structure they have around them. So you have somebody who's a little bit all over the place, but they've got a great caregiving team around them and they have a lot of structural support. They live in a place with multiple other people. They may be okay. And part of the reason that I think we see different sort of compliance outcomes across different healthcare systems is in part because they have a lot more support in some versus others. But it's a great question. I think that afterwards, I mostly sort of like, if you try to intervene with the person individually, and then if they have a solid caregiving kind of plan, then you can pretty quickly pivot to that if you feel like you're not getting anywhere with the person individually.
Thank you. Other questions from the audience? I don't think we have anything from the virtual audience. So. All right, well, thank you.
Thanks.
We appreciate the information. Our next speaker is Dr. Kathleen Ramos. She's an associate professor at the University of Washington in the Division of Pulmonary Critical Care and Sleep Medicine. Her research interests include advanced CF lung disease, access to lung transplantation, and clinical outcomes after transplant. Her active multi-center randomized controlled trial of lung transplant education with a focus on people with CF, particularly with interest in disadvantaged access. Our other active project is pharmacokinetic study of ETI after transplant. She is active in the CF Foundation's Lung Transplant Consortium and is a member of the steering committee. She's the interim medical director at the CF Therapeutics Development Network Coordinating Center, and she's going to present today, Engaging in Transplant Conversations in CF Clinic, a focus on those with disadvantaged access. Thank you, Ken.
Thank you so much for that wonderful introduction and for inviting me to speak today. Thank you for attending this session and for the people who are streaming online. These are the disclosures for this talk. In the next 20 minutes, I'm going to talk about decreased lung transplant access for people with low socioeconomic status, minoritized race, and/or Hispanic ethnicity, the CF lung transplant referral guidelines, some facilitators and barriers to discussions of lung transplant, and potential interventions to improve transplant discussions in CF clinic. So people with CF and lower socioeconomic status, Hispanic ethnicity, and/or minoritized race have lower rates of referral, listing, and lung transplant, and higher rates of death without lung transplant. This is not a new phenomenon, and disadvantaged access to lung transplant has existed as long as it has been studied, and longer. If a person has Medicaid insurance, they have a 2 times increased risk of death without transplant. For those with Hispanic ethnicity, it's up to 3 times the increased risk. People with CF and minoritized race have both decreased access to lung transplant and increased risk of death without transplant in both the US and Canada. In the highly effective modulator treatment era, white non-Hispanic people with CF have experienced most of the benefit related to dramatic reductions in the rates of lung transplant, and that's at least in part due to differential qualification for highly effective modulators in the racially and ethnically minoritized people with CF, but it's also related to systemic biases that disadvantage people of color. So one aim of the CF Foundation Lung Transplant Referral Guidelines was to increase the awareness of lung transplant at an earlier stage in a person with CF's illness so that they have time to consider lung transplant and prepare for the decision-making process. Early introduction includes an annual discussion of lung transplant once their FEV1 is less than 50% of predicted. Early introduction also allows time to address potentially modifiable barriers or contraindications to transplant, some of which may take years to improve. The guidelines also aimed to inform CF clinicians about the importance of using the overall trajectory of someone's clinical course, in addition to FEV1 and markers of increased disease severity to determine the timing of lung transplant referral. And then early referral is emphasized to avoid the need for emergent transplants or missed opportunities for transplant entirely, because a person can become too sick to undergo transplant before they reach the transplant team or have time to get organs. Early referral also gives patients, people with CF, and their families the time and space to fully consider transplant. The guidelines also encouraged seeking out second opinions in cases when an individual is declined for transplant, and acknowledged the importance of improved communication and partnership between CF and transplant programs. So I'm going to share community perspectives throughout this talk because I think the community's voice is critical in understanding how we should approach transplant discussions. During the CFF referral guidelines process, a focus group of people with CF and caregivers addressed the timing of transplant discussions with CF providers, the accuracy of the transplant-related knowledge and expectations that they had, stigma and loss of their CF identity when it comes to transplant, the treatment team transition issues, as well as the importance of social support and mental health concerns. The reference at the bottom of the slide points you to a fantastic paper that Patrick Smith led and wrote, and I'm going to share a few quotes from that paper on the next slide. I remember that conversation about transplant referral very clearly because it was almost like shocking for me. I remember going in for what I thought was a routine appointment and leaving feeling upset and traumatized because I didn't see it coming. I really never thought about transplant. I really never brought up transplant either. I'm just as guilty as the doctor because I was in denial. I think that it would be better if transplant was part of the routine conversations that occur between a patient and a doctor. And then finally, knowledge is power. If you have the information about partnering lung transplant centers at your disposal, you're more inclined to pursue transplant. You'd be less anxious and less nervous. In a separate study about unmet supportive care needs, interviews were conducted at the University of Washington between 2015 and 2016 with people with CF and an FEV1 less than 65% of predicted. Communication about lung transplant was identified as a gap in CF care, and of 48 people with CF who were interviewed, 67% brought up transplant, even though we weren't asking about transplant in those interviews. And there was no difference in FEV1 among those who did and did not bring up transplant. So we performed a secondary analysis of the interview transcripts and identified several potential barriers and facilitators to lung transplant discussions. People with CF may feel apprehension and/or ambivalence about lung transplant if they don't feel sick enough despite having a reduced FEV1. Some view transplant as frightening, and there's a lot of uncertainty surrounding outcomes, particularly post-transplant survival and complications. Some people think that others may be worthier of a lung transplant, and that's partially related to self-identified declines in health that could be related to past non-adherence. Also, a lack of a sense of purpose in their own lives, not yet having a family or not being able to hold a steady job were examples that people brought up to say that maybe they don't deserve to get a transplant because they're not contributing enough to society. And they've already lived beyond their predicted life expectancy. And so why go through this if they've already sort of beat the odds and outlived what they were told in the past? Some people with CF think that they may be too old to receive a lung transplant. And one person said, oh, let someone younger get the lungs. I've already lived a long time. And then people with CF may perceive the discussion of transplant as a difficult conversation for physicians, and they sense the reluctance by physicians to discuss transplant and then infer that physicians' negative attitudes could be either related to the patient's fitness for transplant or about transplant in general. So here's another quote from that paper. I'm almost 60 years old. To me, transplant's not worth it. I mean, at 34, you're told it's going to kill you. The average life expectancy of a CF patient is 23 or something like that. Every year is a bonus year. So when that day comes, I think my kids are going to go, well, he had a lot of bonus years. I wasn't expecting to talk about lung transplant, but at the same time, I knew it was coming, and I could tell that it was difficult for the doctor to bring it up. And then finally, I was starting to get worried about like what happens when the numbers, the FEV1 gets low enough, because we had never discussed it. So I finally just directly asked when transplants are considered. The CF doctor just kind of said, "Oh, we don't have to think about that now. If it drops to 30%, that's when we can start talking about it." These interviews highlight that people with CF are thinking about transplant even if the CF team is not talking about it. And there are unexpected barriers, because thinking you may be too old for transplant at age 60 means you haven't been educated that over 40% of the lung transplants in the US in 2022 were for people over the age of 65. 80%, 75% occur for people over the age of 50. And so that proportion of older people receiving transplants is going to keep growing, especially since there are fewer people with CF getting transplanted. We also identified some facilitators to transplant discussions, and the willingness to discuss transplant may vary over time. It's not necessarily related to lung function, though changes in health status may prompt concerns and/or discussions about lung transplant. Information-seeking individuals may be more inclined to discuss lung transplant. Some people want to know everything about everything, including transplant. There was a focus on the FEV1% predicted. People often called it the numbers, and people with CF take cues from their CF team about the meaning of those changes in their FEV1, and they also suspect that there may be specific lung function thresholds that trigger either transplant discussions or decisions, and if they don't know what those thresholds are, then they keep anticipating, well, when are we going to talk about it? What's the number? And then lung transplant discussions need to meet a variety of needs, and the people with CF really rely on their physicians for accurate information, and they're looking for ways to put their own experiences into context. And when physicians explain that transplant is not yet medically indicated, it may actually ease their fears and open doors to future discussions about transplant. So here are some quotes from that paper as well. They answered all my questions as far as improved quality of life. How often do they see lung transplant in patients with my sort of, in my bubble, I guess, and also then typical life expectancy. They were honest with me, and I appreciated that. The doctor is like, well, if I send you to the transplant team, they will be laughing at me. So that was the latest discussion. I was like, good, phew. The first time they had mentioned transplant, or the second, I kind of didn't want to hear about it because I wasn't even looking in that direction. It just scared the crap out of me. And then as things got a little worse, I asked more questions, and they were totally fine explaining it. So support from healthcare professionals, family, people who previously received a lung transplant, and close friends play an important role while people with CF are waiting for lung transplant. Education about lung transplant, disease trajectory, care after the operation can improve knowledge, preparedness, and transplant-seeking behaviors. Use of more adaptive framing to describe post-transplant complications can reduce anxiety related to transplant. For instance, describing complications as treatable components of a chronic disease is more helpful, and these complications can include diabetes and osteoporosis, and skin cancers and infections and rejection. But almost all of these complications have treatments as well. People with CF prefer to avoid having transplant discussions during a crisis, and so it's better to talk about it when they're not having a hospitalization for an acute exacerbation. So there are 2 prior decision aids that exist for lung transplant for people with CF, but one is out of date and no longer accurate, and the other was more focused on end-stage lung disease decisions related to mechanical ventilation and transplant. And so to address the gap in resources for deliberation about lung transplant for people with CF, both who are close to transplant but who are further removed from the decision, we co-produced with the CF community an up-to-date CF-specific guidelines-based educational resource about lung transplant called Take on Transplant. And it's not publicly available yet because we have an ongoing multi-center 9-site clinical trial that's currently enrolling. And I'm going to tell you a little bit about Take on Transplant. So it has 4 components that are based on our prior research. And the first is My CF Stage, which is an assessment of disease severity and whether somebody's had a prior discussion about transplant. And it provides personalized recommended content based on the responses to the survey. There are CF stories, which are personal narratives from individuals with CF and caregivers sharing firsthand accounts of the transplant journey. And it's enriched with people from disadvantaged backgrounds and with backgrounds that are disadvantaged in their access to lung transplant. There's a resource library that has CF-specific medical information about lung transplant, and then frequently asked questions that are common questions and answers about transplant that were provided by people with CF, and then also answers were provided by CF and transplant physicians. So the Lung Transplant Ready Pilot RCT was an intervention of Take on Transplant compared to UNOS.org, which we used as a control in our study. We enrolled 50 participants from December 2021 to November of 2022 with the aim of determining the effect on preparation for lung transplant using the Preparation for Decision-Making Scale, or PrEP-DM. We included adults with CF with an FEV1 less than 50% of predicted who had no prior lung transplant, and we recruited from centers all over the country. We oversampled what we termed communities of concern, and those are individuals who have disadvantaged access to lung transplant, Medicaid insurance, minoritized race, Hispanic ethnicity, and/or high school education or less. And what you can see here are the demographics of the participants in the pilot RCT. And I want to call your attention to the fact that 92% of the participants were taking ETI at the time of the pilot RCT. And importantly, we found that individuals from these communities of concern were very willing to participate in our pilot RCT and made up 62% of the cohort. Take on Transplant improved preparedness for transplant decisions at 2 weeks and at 4 weeks, and the 2-week data was our primary outcome. You can see here that the PrEP-DM score was higher, and higher is better for the Take on Transplant group compared to UNOS, the control arm. And the communities of concern had lower baseline lung transplant knowledge, more limited health literacy, but achieved a similar benefit from the Take on Transplant intervention across all the measures that we looked at. We also did interviews after the 4-week pilot RCT, and we did a qualitative analysis of 25 transcripts, 68% of which were from these communities of concern, and 2 coding families really emerged, and they confirmed similar themes to the studies from before the availability of ETI. And so that's why I felt confident showing you that prior literature, because the same themes are still coming up. Early education is beneficial. As worsening disease occurs, it influences engagement with lung transplant information. So there's variation in interest in this over time. Relevance to self was a key theme that came out, and understanding the context of their own experience compared to others is really important. And we identified some specific information that participants found useful. We also understood more about the emotional impact of both engaging with the websites, but also thinking about and talking about lung transplant, and then found that information may motivate lung transplant preparedness and decision-making certainty. So we hypothesize that the participants from these communities of concern may place greater importance on financial concerns or concerns about having adequate social support or being a burden on their caregivers when making decisions about transplant. And we were also interested in understanding whether or not there was a difference in how relevant the Take on Transplant content was perceived to be in the communities of concern versus those who were not in those communities, and whether or not they had ever experienced provider bias that would negatively impact their decision to pursue lung transplant. There were no explicit statements about experiencing provider bias among our participants, and so we further explored whether or not there were statements made about feeling comfort or discomfort with talking about transplant with their CF clinicians. And so in this analysis, the transcripts were reread deductively in a hypothesis-driven way to identify specific statements that were made by all the participants about these topics, and we compared the responses between the participants in communities of concern versus not in community of concern. And what you can see is actually a very similar proportion. Let's go back. Okay. A very similar proportion of the people in the communities of concern versus not talked about social support or being a burden on caregivers during the transplant process. The relevance of the lung transplant information may have been slightly less for the participants from communities of concern, but what stood out to us the most was that the financial concerns related to lung transplant did seem to be mentioned a lot more commonly in the communities of concern, and there was no difference in their comfort talking with their CF clinicians. A quote here from a member of the community of concern about financial concerns was, "Am I going to be able to work after I get this? And are we going to be able to pay our bills with disability?" So there's several implications here. People with CF have dynamic lung transplant information needs that evolve with disease severity, even in the setting of ETI. Transplant education affects knowledge and preparedness for decisions and for discussions and decisions. Early introduction to lung transplant education was favored despite high rates of ETI use. And CF-specific information about lung transplant and take on transplant was highly relevant and increased people's motivation to act. And barriers to lung transplant exist for individuals in communities of concern, and one of which may be financial concerns related to transplant or access to more relevant information about transplant. Knowledge gaps remain. We need updated data related to prognosis without transplant in the setting of advanced CF lung disease on ETI, as was discussed earlier. The role for lung transplant education for children who start ETI at 2 years old or down to 1 month old, I'm sure in the future. We don't know what the role of lung transplant education there is, although I would argue that anticipatory guidance is a key feature in pediatrics, and you may want to talk about the fact that it could be a treatment option. It may not be, but it could be. And then interventions to address social determinants of health and transplant access for people with minoritized race and/or ethnicity are still lacking. So in conclusion, early introduction of lung transplant can help people with CF mentally prepare, psychologically prepare for the transplant discussion and decision, and can also help with modifying potential barriers to transplant, financial, social support, nutritional adherence issues, which may take years to improve and may be more salient for those with disadvantaged access to transplant. And it's critical for our community to know that lung transplant program practices evolve over time, and what used to be an absolute contraindication may not now be an absolute contraindication. And so some things that may have stood in the way 10 years ago may not now. Uniform early introduction may actually increase equity by avoiding discussing transplant only with those who are considered good candidates. If you talk about it with everyone, then maybe there's less bias in that. And people with CF from these disadvantaged backgrounds are willing to engage in these discussions and made up a good deal of the people who participated in our study. Up-to-date CF-specific information is critical, and it increases the perceived relevance of lung transplant education. And CF provider attitudes about transplant are at least somewhat perceptible to patients and families. So it's important to be honest and direct, but don't say that transplant is a death sentence, because it sticks with people. And people with CF are looking to their care team for information about lung transplant, and outcomes in lung transplant are improving over time. It's one of the things that was shown in multiple studies. The more recent years are getting better and better. And so just making sure that we're accurate in the information that we give and aware of our own biases for or against transplant. And then, back one more, sorry. And then disadvantaged access to lung transplant exists for people with CF who have Medicaid insurance, Hispanic ethnicity, and/or minoritized race, and interventions that are aimed at improving preparedness for lung transplant should be adapted for people at the greatest risk for needing transplant and/or at risk of missing their opportunity for transplant. So I wanted to highlight relevant 2023 NACFC abstracts for people to look at afterwards. And then I have 2 slides of references that were at the bottom of the slides. And then a big thank you to everyone who helped with making Take on Transplant, doing the pilot RCT, and writing the CF lung transplant referral guidelines. That's it.
Thank you so much for everything you do for the community. It'll be really exciting to have that Take on Transplant tool once it's for prime time. A couple questions from virtual. One is there an option to provide report outs of where a patient is in their educational journey? to their CF center or transplant center, allowing centers to better address their needs and meet them where they are in their knowledge and understanding? If not, would this be considered for future development and implementation?
Yeah, that's a great question. And, you know, we have on the Take on Transplant website this lung transplant discussion urgency meter, which I flashed on the screen. And it's really informed by the lung transplant referral guidelines, markers of increased disease severity. And if you enter into the survey that you have these markers that you should really be getting referred for transplant potentially, but you haven't had a discussion of transplant with your provider, then it increases the urgency of the discussion. And so the people with the highest urgency are people who really should be talking about and thinking about and planning for transplant, but haven't yet had that conversation. And so you certainly could print out your report, your score, and it is printable, and take that to your doctor and say, look, I'm supposed to be talking about this.
Another question from our virtual attendees. You mentioned transplant referral guidelines. Do we need to reconsider when to refer patients in the era of ETI?
So yes, I think that we are reconsidering it all the time. And I think that the referral should still be early. And there is likely to be prolonged survival with advanced lung disease on ETI. There are data from the CFF registry from several years ago, before the existence of widely available modulators, that showed a median survival of 6.5 years when an FEV1 is less than 30% of predicted. And it's likely that some people are going to live 10 years with an FEV1 less than 30%. And so the comment that this is going to be a quality of life decision potentially is absolutely salient. And so talking about it at the individual level and deciding a person-to-person discussion about when to refer and when to get listed, I think is really important, because referral is not without risks. Obviously, it's anxiety inducing to people with CF to think about it. There's a lot of logistics of needing to go to a transplant center and costs associated with that. But the benefits of going and talking to the transplant team early, you can identify things that you didn't even know were barriers. You didn't realize how expensive it was going to be or how much time your caregiver was going to have to take off from work. And you can make plans then by going early and talking to the transplant team. So I still think that even in the setting of ETI, we should be referring people early, but just counseling them ahead of time. This doesn't mean you're going to get listed for transplant. That doesn't mean you need a transplant right now.
I was wondering, the change with the race-based or race,
FEV1.
yeah. Do you think that's had any impact on the slow referral for people of color?
That's a great question. And I think that it could potentially play a role since people have been so fixated on FEV1 less than 30% of predicted for a really, really long time as, the threshold when to think about it, then people who are Black and have, artificially higher FEV1% predicted may have been even more delayed in having discussions about transplant, and perhaps taking the race-based equation out of the picture will make it so that we'll talk about transplant sooner with people who are Black. And so maybe. I don't think we know yet.
Sure.
All right, there's a few questions that maybe we'll bring to the panel at the end that may be a better group discussion.
Okay, great. Thank you.
I did want to mention to our virtual audience that we are getting some questions that are very sort of patient, individual specific, and we really can't answer those, without truly knowing your history. So unfortunately, we can't answer those in the context of this session.
Great. Thank you.
And then I have the pleasure of introducing our last speaker today. He probably can go without introduction for all he's done for the CF community, but this is Dr. Joseph Paluski. He's an Associate Professor of Medicine, Pediatrics, and Clinical and Translational Science at the University of Pittsburgh Medical Center. He has a long history of basic and clinical investigations related to cystic fibrosis and lung transplantation. He has been the principal investigator in numerous investigator-initiated and multi-center clinical trials in CF, and he has served as the medical director of the lung transplant program and CF Center Director at Pittsburgh. He is the co-executive director of the CF Lung Transplant Initiative, and he is leading research efforts to improve the care of individuals with CF before and after lung transplantation. Today he's going to be discussing with us the role of multidisciplinary CF teams in post-transplant care.
Thank you very much, Emily. That's too kind. It's a pleasure to be here today, and I'm speaking on behalf of a group of people who got together and formulated a proposal for how multidisciplinary care teams, care members in CF and transplant programs can meet the needs of patients who've undergone transplant. So we'll go over those things and hopefully have plenty of time for discussion later. I have no disclosures, but I think it's clear to everybody that I'm a strong advocate of lung transplant for CF because I believe that it saves lives in many situations where we thought it wasn't possible. So I think it's important to put this in the context of the transplant journey and where this work fits into that. So Aaron Tallarico and the group that worked initially with the Learning and Leadership Collaborative, sponsored by the CF Foundation, sort of broke down the transplant process into this journey that starts with a conversation about advanced lung disease that Kathy nicely referred to, that referral process, and then it kind of goes into this black hole that varies from transplant center to transplant center of an evaluation, a committee meeting, and a decision about candidacy. That then leads to waitlist addition, potentially lung transplant surgery in most cases, and then you have this early post-lung transplant course where people are recovering from their surgery and their care is under the direction almost exclusively of the lung transplant program. So the Lung Transplant Initiative, that's thankfully been funded beautifully by the CF Foundation over the last 7 years now, has addressed many aspects of this journey. But one aspect that we hadn't heretofore addressed is shared care. What happens to people after they complete their transplant, recover, and leave the hospital? So we're going to talk about the work that came out of a panel, international panel of experts in both CF and lung transplant with some community members and what we thought would be ideal for post-transplant care. So I think it's clear from the previous discussions, wonderfully done by Ann and Patrick and Kathy, that we really have opportunities to increase survival after transplant. The current survivals are suboptimal, meaning the median survival is 10 years, and granted, it's great that it's better than other lung diseases that come to transplant, but it certainly has a lot to be desired. And it's important to remember the range is really wide. I think sometimes people get this misperception that 10 years is it. When I get to 10 years, say goodbye. We have people who are now 30 years after transplant, even when they were transplanted under practices that have been shown to be, frankly, suboptimal. The major causes of mortality after transplant include rejection, infection, malignancy, and complications of renal disease. And while not all of these are addressable, clearly having a multidisciplinary team trying to optimize the evaluation and care of people to detect these problems early is most likely to lead to improvements in outcome. We have gaps in post-transplant care for sure. In the CF patient registry analysis that was completed with a cohort from 1986 to 2017, published by Whitney Brown and others recently, 18% of the 2,500 individuals in the registry who were lost to follow-up were transplant recipients. So that's a significant number of people who we would infer were not at all seen in their CF care center after transplant. I will say from my experience, the engagement of CF transplant recipients with their CF programs varies widely from they never go back to their CF center, to very, very, very regularly, annually, quarterly in some cases. So that differential experience may impact what happens to people after transplant. And I think it's safe to say that there are some lung transplant recipients who sadly die from manageable complications such as cancer because they fail to receive cancer screening early enough to detect things like colon cancer that could be treated if it's detected early. And I point you to a blog that was written by Jerry Sweeney about his daughter on the importance of self-advocacy after transplant based on the tragedy of his daughter dying 10 years after transplant with perfectly functioning lungs from metastatic colon cancer. So we'll just put this in some context with a case study, and I think it gives us a framework to think about how this committee was faced with decisions for formulating, establishing models of care for the community. So this is a 28-year-old woman with advanced CF lung disease, multi-drug resistant Pseudomonas, referred by the same state CF center, so 160 miles from the transplant center, for transplant evaluation. And her course was really quite uneventful. She was evaluated, accepted for listing, transplanted after a significant wait thanks to the previous version of the lung allocation score. She stayed local to the transplant center for 2 months after hospital discharge, engaged in rehab, and then was ready to go home. So what should happen to her after she leaves? What should the plan of care be for her home location? Well, one model, and I think one that oftentimes occurs, is that all the care comes at the transplant center, and that may or may not involve the engagement of physicians who have expertise in CF and the non-pulmonary issues. A second approach would be shared care between the transplant center and the referring or another CF center, or all care at the transplant center by a CF transplant physician. And so these were the sorts of discussions and options that we pursued. In order to think further about this, we wondered, well, what are the issues? What are the multidisciplinary needs? Because that, in many cases, may drive the model. So we know that care after transplant is complex, and it requires subspecialist care from many different disciplines. And I've listed some, but not all of them here. Diabetes, osteoporosis, sinusitis remains after transplant. We see a lot of GI issues with gastroparesis and GERD, liver disease, renal disease, very common as people live longer after transplant. Financial issues, certainly in our broken healthcare system, this is oftentimes a problem. Mental health challenges that Patrick nicely addressed, malnutrition in some cases, and the converse of obesity, reproductive health. So survivors after transplant contemplating parenthood, that's a really important issue. Cancer screening, I mentioned already, skin, colon, others, and then lastly, transplant infections. So a wide variety of individuals are oftentimes involved optimally to provide care after people who've undergone transplant. So where do they get that care, and how do we help ensure that that multidisciplinary care happens? So we had a number of sort of guiding principles that came out of our discussion, and these would be regardless of the selection of the model. So the first is that the transplant team really should and needs to direct all aspects of pulmonary care and manage immunosuppression indefinitely. Many transplant centers do this granularly because they feel like they own the lungs that they had somebody get replaced. So that is a relatively easy thing to navigate. A second really important guiding principle is that the CF and transplant teams establish a working relationship and ways to communicate in a timely, intentional, and effective way. Many people thought that the important principle would be to have a single physician or provider to serve as the lead coordinator in the post-transplant care management, and to help ensure subspecialty referrals, because they have the greatest breadth and understanding of what happens to people after transplant, where the landmines are, and how to address them. Lastly, visit frequency would vary over time. It should evolve and should include telehealth. The advantages of that are obvious to people in terms of quality of life, frequency of contact. Telehealth has a lot to offer for long-term care of people with complex needs. Transplant follow-up would be very intensive early and frequent, but the CF needs then would oftentimes be secondary. And then as time evolved, you would look at a model perhaps that would have quarterly CF visits when the transplant issues took a back seat. But at minimum, patients should be seen by their CF center on an annual basis to ensure there are no gaps in non-pulmonary issues. So the committee derived 2 models of care, and these are outlined here. The one on the left is a shared care model. The one on the right is a more consolidated model where the transplant center manages and coordinates all aspects of care. So we're going to break these down a little bit and get a sense of what the models provide as a framework. We'll do that first with a case study, a 26-year-old man with advanced CF lung disease and chronic respiratory failure, chronic Burkholderia sinusopatia, referred from 550 miles away from the transplant center by a CF physician who made a personal phone call to a transplant physician to advocate for the patient after she was having difficulty identifying a transplant program willing to take the risk. He was evaluated for transplant, accepted for listing, relocated, listed, and transplanted, and things went very well. He remained in the transplant city for a year, and then it was time to move home. So clearly there are geographic constraints that feed into this, but the questions we addressed before he left were who should manage his CF issues after relocation, both before and after transplant. So before transplant, the local CF center assumed responsibility for his care and tried to ensure that he remained in good condition to undergo transplant. Then after transplant, what would that have to look like? Clearly, it's a distance relationship. Who would manage the CF? Well, we thought clearly the local CF team would be the logical candidate to take care of the CF issues. And because the physicians had already had a well-established relationship, it was very easy to transition to a situation where the CF provider was seeing the individual on a quarterly to 4 times a year basis, and the transplant team would see them by telehealth at a little less frequent basis, and we minimized the trips back to the transplant city once a year. So this model outlines basically complete shared care, where the CF program refers for transplant, the transplant team does the transplant, and then the transplant team focuses on the transplant issue, and there's an establishment of a local CF care program who would oversee all the non-pulmonary CF-related issues, from diabetes to sinusitis to other aspects that crop up from a CF standpoint after an individual has undergone transplant. One advantage of this model is the perspectives on Trikafta utilization. So we've pushed that people who are going to start Trikafta after transplant, it should be a shared decision between the transplant center, the CF center, and the individual, and not be something that the CF center does, certainly without engaging the transplant center with that decision-making, given the interactions with drugs and other complications. In this particular, the case I mentioned, the individual had a trial of Trikafta for residual sinus disease and developed significant pulmonary toxicity that required cessation of the Trikafta and intervention with steroids to get him back to his baseline. So what are the considerations and expectations for Model 1? A single provider is identified to oversee the care of each transplant recipient. Effective communication between the CF and transplant teams is intentional and ideally should be established prior to transplant. The CF team should receive some written material and a summary, ideally a verbal report about the course of the transplant, how the person's doing, their complications, and key care elements that should fall under the attention of the CF team after they relocate to their home place. After transplant, CF clinic appointments should occur within 6 months and sooner if input is needed on non-pulmonary issues such as diabetes, GI issues, or ENT. So one important part of this is to make intentional decisions about the care distribution between the CF team and the transplant team. And we outline these things. The transplant team should manage immunosuppression, should take care of all aspects of pulmonary surveillance, including pulmonary function, imaging, and bronchoscopy. They should take control over surveillance and management of infections, including CMV and EBV, and all lab monitoring with management of immunosuppressive levels and some of the toxicities associated. The CF team can be helpful with diabetes management, management of bone disease, because that's an area of expertise, GI issues, particularly enzyme replacement and liver issues, and nutrition, because they're well-staffed to manage post-transplant nutrition issues. And then up for discussion in particular are things like malignancy screening, so it doesn't get lost in all the other care needs, including but not limited to colorectal cancer, employing the colorectal cancer screening guidelines that the CF Foundation published in the late 2010s. A sinus disease can occur at either location depending on expertise. Mental health concerns, I think we do a pretty good job pre-transplant, but we have a lot of work to do on post-transplant mental health concerns. Patients come out of transplant with PTSD, anxiety, depression, and in many cases, how well they cope after transplant has a major impact on how long they survive. And then also social work needs, there's a lot of intention and a lot of attention early before transplant, but afterwards sometimes it's very hard to find a social worker who has the expertise to navigate the complex insurance and other psychosocial needs of people who have undergone transplant. Model 2 is a simpler model where the transplant center has expertise to manage all aspects of both transplant and CF care. So in this model, the CF program, usually within the same institution, refers the patient for transplant. The transplant team completes the transplant, and then that program and their CF expertise provider takes care of the CF-related issues. So the considerations and expectations in this model are listed here. All components are of the CF multidisciplinary care team should be located at the same institution as the transplant center. It's hard to do this in geographically disparate areas. Physician care for the CF lung transplant recipient, the physician caring has expertise in both lung transplant and CF and access to multidisciplinary CF care team members. Again, a single named physician or provider can coordinate care and is willing to take on that responsibility. And then the physician and multidisciplinary team members are competent in all aspects of routine post-transplant and CF care. So this is a brief case study. We'll do this quickly because it's relatively straightforward. A 60-year-old male truck driver with hypoxemic respiratory failure due to pulmonary fibrosis and a late diagnosis of CF had confounding issues of obesity and diabetes, referred from the CF center to the lung transplant center at the same institution. He was initially deferred transplant listing for lack of financial resources for travel from 2 hours from the transplant center for his post-transplant care. So this was a test of the social work situation and where the resources can come from. In this case, we had questions of who's going to support the fundraising to enable transplant listing. And it turned out in this situation, the CF social worker had much better familiarity with Compass and the other resources from the CF Foundation, grants that could be obtained from philanthropic groups so that he could have a reservoir of funding in order to undergo transplant. After he's listed which team manages the complex lung disease, obviously it's the CF center. He undergoes a transplant 22 days after listing, goes to local lodging on post-op day 16, and then goes home. What should be the role of the CF center? Well, in this case, we're advocating for annual visits to the CF center to see all the multidisciplinary care teams, because the person who oversees the care in the transplant clinic knows about CF. So a number of factors can help us decide which model is most appropriate for an individualized person. The approach of the transplant center sometimes influences whether it's a longitudinal provider model or a group practice provider model, so that the willingness to have one assigned transplant physician sometimes varies from transplant program to transplant program, and it's important to take that into consideration. Obviously, expertise by team members matters. Geography, we have many patients who travel distances to undergo transplant, and we have to be sensitive to the demands of traveling great distances to achieve care. Insurance and financial resources, we all know that insurance companies dictate which hospitals many patients are able to go to, so that oftentimes influences the care model that you establish. We always ask for healthcare options and have clear healthcare options for people who have urgent needs, so not getting caught in the middle of the night when somebody gets short of breath, that they have a place to go and they clearly have communication methods back to the transplant center. Patient preference, physician preference, those all should be considered, as well as access to subspecialists with CF expertise. Most CF centers have that to a great degree. Some transplant centers do, others do not. And then the person's social support can guide what kind of individual care model is important. So one of the quality improvement initiatives that came out of the Learning and Leadership Collaborative is something called the Regional Dissemination Network. So Margie Godfrey and her group at the University of New Hampshire, with funding from the CF Foundation, has established relationships between transplant centers and regional CF centers who use those transplant centers. So a number of best practices were identified from this work over the last couple of years, and we'll just share a few of them based on those observations. Some centers have created virtual regular meetings between the CF and transplant centers to review patients. It's a beautiful way to get updates and keep both teams engaged and aware of what's going on. Virtual monthly educational sessions so that the CF teams could learn about transplant and vice versa. Those were very helpful with presentations by an expert in the field on a topic from one of the centers. A refer back mechanism or a form for post-transplant handoff, and then creation of a contact list. So it wasn't a struggle. You didn't have to go through a phone tree. Simple things to find out where somebody would go to get their care. And then a co-management document, something that really outlines who's going to oversee which aspects of care, who's going to make sure the vitamin levels are good, who's going to ensure the cancer screening. Having responsibility and clear delineation of that would be very helpful. So in summary, what I've tried to do is outline how optimal care of individuals with CF who've undergone transplant requires a lot of attention to CF comorbidities. Our group outlined 2 models of care to provide a framework. One, a shared care model between the transplant and CF programs, and a second, consolidated care within one institution. We can look at the variables that go into these decisions and most importantly, perhaps have regular communication and clear understanding among the transplant recipient, their family, and the CF and transplant providers. And having one lead person to orchestrate that is really critical. So I'd like to acknowledge and thank the people who contributed to this work. Ed McComb was the co-chair and helped contribute to the publication in the JCF earlier this year. So much of what I've talked about today is in that proposal. This is a multinational group. We had folks from Spain and England and support from the CF Foundation, and we really appreciate all of that. And I'll give a shout out to Aaron Talarico and Abby Boyle and Abby Thaxton at the CF Foundation for helping to keep us on task. So thank you for attention and the opportunity. I'd be happy to take questions and have some discussion.
And contrary to what we told you before, we're going to actually ask the panelists to come up because there are a number of questions that have come up sort of over time. So if you guys want to come up, because there are questions for sort of everyone here. What?
Chris Goss from Seattle, and Joe, thanks for a great talk. I was wondering how the group will think about how the new what Ann showed us, this dramatic fall in CF transplants, is going to affect these models, because you could see in 5 or 10 years having very little experience with CF at transplant centers. I mean, it seems that could be likely if the numbers go down to 1 or 2 a year. How should we think about that change with these care models? Because it seems like that would really need to re-engage the CF center more commonly than is currently done.
Yeah, I share your concern on both ends that the people at the transplant center won't have much knowledge and experience, and it will be a reinventing of the wheel. We all know that volume drives success in many cases, so if you do something more times, you generally get better at it. If our experience becomes limited at many transplant centers, it's going to set us up for potential complications. I think the education is really the key. CF centers partnering with transplant centers and educating them. The second thing is that the transplant centers may need to have much more intentional discussion of management prior to transplant on things around infection. So many transplant centers don't have a lot of experience with some of these multi-drug resistant bugs that are evolving over time. And having the transplant center know who at the CF center can give advice and provide input is one example of how regular intentional communication could be helpful. It's a little politically challenging to try and designate transplant centers as being expert in CF transplant. I think that's something that has to be at least considered, given what we know about volume driving outcome. So I don't have any answers to that. We all know that choosing where you get your health care is really important. Many of us have probably personally experienced that. How you guide patients and families in that process, I think, is very difficult. So a really important thing. I wish I had a good solution.
Dennis?
Thank you all for the excellent presentations. Two questions. One is probably more directed towards the US-based transplant physicians. So recently I was looking at UNOS for something that I was preparing, and it looked like if you look at the number of transplants for CF annualized for 2023, it looked there's going to be, after a consistent drop over the years, either a stabilization or a slight increase. So the question that I have, and this might be speculation for the group, do you think this is related to the fact that maybe the people that stabilized but already had advanced lung disease now are coming back down? Or is it related to the new CAS allocation, which actually clearly provided, benefit to people that are younger, and that would help, the persons with CF? So that's the first question.
I'm not sure that's going to work. Is this one? Okay. Well, I think that the data are really interesting, and I'll add to it to say that we talked to Liz Cromwell at the CFF and got some insider information from the registry data. And right after the referral guidelines came out, the ratio of deaths, of lung transplants to death, improved in the US. And over the last year or two, the ratio has worsened again, and there are more deaths without lung transplant than lung transplants. And so I suspect that people are having bad outcomes despite the availability of Trikafta. But the data that Anne shared, that Dr. Stevenson shared, showing that it's only about a third of the patients who are on Trikafta when they get transplanted, means that, maybe Trikafta, progression despite Trikafta is part of it, and it's almost definitely that they had advanced lung disease when they started the drug. So, but I think there will be more people who are on ETI who need lung transplants over time. This is not a cure.
No.
And I think that we all have to be careful about over-promising, you're never going to need a lung transplant to people who started Trikafta as an adult, because we do not know that they are never going to need a transplant, and maybe they won't need it in their 30s, but they may need it in their 50s or 60s. And by need, I mean the alternative is that they will die from their CF lung disease. Nobody wants a lung transplant. Nobody wants chemotherapy for a cancer, and nobody wants, open heart surgery. But if they can't walk to the door because they're having chest pain, then maybe they need to have a surgery to relieve that symptom. And as we talked about earlier, the quality of life related with advanced disease on ETI is going to drive part of that decision-making process too. So, long answer.
Yeah, I think we don't know yet about the percentage of people on ETI who will have what I like to call the rapid progression. Those are the ones that I lose the most sleep over.
Yeah.
Somebody who's on oxygen, a little hypercapnic, and they seem to be okay, sort of, on ETI,
Yeah.
but you know that they're at risk for having a rapid decline. If they're not on ETI, I think that risk is even higher, just based on our experience, right?
Yeah.
They
That's
seem to
sensitive.
go down, when those individuals go down, it's really sometimes amazingly fast. And so having things ready and a safety net is one of the main goals of this early referral, education, decision-making process that we're trying to do better with.
And massive hemoptysis is still happening, and people can die from massive hemoptysis despite ETI, so.
I mean, that's how we've lost, like a couple of patients, basically,
Yes.
which were in the process of being listed, actually. Yeah.
Yeah, I think unfortunately, the non-CF bronchiectasis patient population is not well characterized in any
Yep.
registries. Ideally, you would have that as a comparator group to at least learn something. But it gets lumped into this suppurative lung disease bucket, to my knowledge, in the registries. Maybe in Canada's a little better, but it's a hybrid between IPF and COPD, right? The progression's going to be somewhere likely in between.
Thank you. And then the second question is mostly for Patrick. So you basically clearly delineated that there's different, personalities. Is there a take-home type of thing that we can get from either a social worker or a psychologist, evaluation, that can help us help the patients on how we talk to them about it. Because, Kathy has presented very nice data about people wanting to learn, more early, which is absolutely true for the majority. But there's also the minority of person that they hear about it and it's like they have the opposite reaction. So is there a way for us, to be able to kind of tailor make our message a little better, and can we identify that?
That's a really good question. I think there's not like a one message kind of thing, but one approach that I kind of like is people want to have control over what they're kind of the way that the process kind of goes, and oftentimes you can give that to them in some areas, but not in other areas. You can dictate to some degree the kind of the guardrails. So I think we've actually talked about this in some of the other projects we were on. But you can do things where it's like, you need to learn a little bit more kind of about this. How would you like to go about kind of doing that? Or, in the past when you've kind of had to learn about different aspects of your medical care, like what's worked sort of best for you, something where it's sort of like there is a path that we need to kind of, follow, but you have a lot of control about how that's going to kind of go. Or maybe, maybe the timing of that, something where the person is they do still have some control over what they're doing, but there's also a little bit more of kind of, we really need to kind of push you in this direction, if that makes some sense. I think you get some people where they just, I forget who said this before, but kind of they want information about everything. There's some of those folks that's kind of the profile. The people that I worry about the most are the ones that are kind of more avoidant, neurotic, right? Exactly, yeah. So I think for those people, I usually those are people that when I'm talking to them, I take a lot longer in the sessions. I take a lot longer actually saying nothing, just letting them kind of like it sink in, where they don't have to do something about it tomorrow, but they do have to do something about it, and that can kind of go and that can be personalized in some way. But I think kind of like giving them space to kind of like yeah.
To piggyback on that, one question that I think can apply to multiple of the speakers, virtual attendee is asked, what would you recommend someone who hides their depression in fear of not getting a transplant due to their depression? Depression.
I think, that's a really good question. I think there's sort of two thoughts that I had. You have a lot of people where there's a specific, you might call it depression, but it's more like an adjustment reaction than the fact that they're going to need sort of transplant. And for many of those people, how people react, this is one of these things where transplant is like, it's partly a clinical recommendation, and it's like half a projective test, because like what you think about transplant, how that resonates for you is going to be really different across people. So I think those are folks where if there's something specific about transplant they're really worried about and their mood's kind of down, it's really about that, directing them to kind of a lot of the things that Kathy's doing, where kind of like they've got other people they can talk to, where they can get more information about it, where they can kind of feel a little bit more empowered about it. I think for other folks where it's more of a chronic thing, and there's other aspects of it that they've been dealing with for a while, it's just trying to link them into treatment in the more traditional ways. We're like, transplant is a specific kind of thing that they're going to have to kind of go through, but this is part of a longer pattern. Trying to kind of tie them in with therapy in the traditional way, I think is useful.
And also recognizing that well-controlled depression is not a contraindication to getting a lung transplant. It's when the depression affects your behaviors, like Patrick was talking about earlier, when you don't take your medications or go to your appointments or can't function in life because of your depression, because it's not well managed, that's when it's a problem. And so focusing on getting into treatment so that you can optimally engage with your care is important.
Yeah, I can't tell you the number of people I've had that have been really worried about the transplant process, and when you actually look at what they're doing, they're meeting all the behavioral, requirements. So it's understandable that they're really worried about or kind of down. It's a big thing to have to kind of go through, and I think as was mentioned before, you don't want to have to do it unless you need to. But for people that do need to do it, as long as they're meeting those sort of behavioral requirements, that's the first thing I worry about, because you worry about them just not being able to get the life-saving treatment that they need. And then beyond that, obviously improving for quality of life and everything else is great.
And I would say being very open about your depression, whether it is controlled or uncontrolled, because that's likely a factor contributing to your CF care as well. And so, really want to encourage everyone to be open about it.
I was just going to add also, I think in Canada anyway, in our center, there's a big transition between getting care at your CF center and then going to the transplant center. They know us so well, we know them so well, and sometimes it sort of is a bit heartbreaking to sort of send them over to the dark side over at Toronto General Hospital. Not that they're not great there, they are, but I know that it's going to be a really hard mental adjustment for them because they don't know the team They're going to be dealing with all these new things. So I think we need to be better at preparing them for that aspect of the whole transplant process.
Can I mention one last thing? I should have said this at the beginning. I think it's also important to normalize it. Like if I've oftentimes told patients when I'm asking about their mood and stuff, and it's like, if you're not a little bit anxious about this, then you're not paying attention. you're going through this life-saving treatment. You're gonna be asked to do all this stuff. Like, it's normal to be distressed going through that. So that part's expected. It's more just kind of making sure it's not getting in the way of what you need to do. But if you're not a little bit distressed about having to go through this life-saving thing, that'd be unusual. That's okay. So normalizing it, I think, can be helpful in addition.
And I've had that exact same conversation where if you're not a little worried about this and you haven't heard anything I said.
Right. Yeah.
I think unfortunately we're out of time, and terrific presentations, and really appreciate spending the morning with us, and thank you to all of you.